Yes, sir.
Okay. So actually, training in medical simulation, this is how the topic is given instead of just saying crisis resources management. And here, the principles dealing with the cognitive and interpersonal relationship contribute to the optimal team performance and achieving the best results for the patient. That is also to be included in the definition of crisis management resources. And it originated in the aviation industry, and human error is the main cause of accidents. 70% of the aviation accidents were because of human error. So in order to avoid that only, they wanted to introduce this concept of crisis resources management. So teamwork helps to make up the deficiencies and the lack of technical skill, and critical recognition of the development of simulation-based resource management training program were introduced, and the four things that were importantly done are leadership, communication, situation awareness, and resource utilization. Or some books say, you can say, decision making and communication and situation awareness and resource utilization. So this
Yes.
part can be sometimes asked in your theory paper as ANTS, ANTS, ANTS. Do you know
Okay.
what is the expansion for ANTS?
Anesthesia, non-technical skills or soft skills.
Non-technical skills.
Skills.
Okay, so that
Yes.
also is a part of this crisis resources management. Sometimes that is also as a question where you have to describe only this. And
Yes.
it was the healthcare, our anesthesiology was the first specialty to incorporate these principles in training the clinicians. And it was the original idea of David Gaba and his colleagues in late 1980s. And they focused on the patient management and not on the behavioral aspects of team performance. So it is mainly to achieve a successful revival of the patient. And to address this, a simulation-based course were done. I don't know how many of you have attended the simulation courses which are offered during all the CMEs and other programs as a workshop. If you have attended any of those simulation workshops, you would have, you could get a better vision or a better concept of this crisis resource management. And they will give you the scenarios of a patient suddenly desaturating intraoperatively, or a patient are developing acute hypotension, or a patient developing severe bronchospasm. Like that, all the clinical scenarios will be given, and you will be asked to describe how you will manage in that. If you are a lone anesthetist, then it is very difficult to do all the needed revival treatment alone. So in that situation, calling for help, as he rightly said, and getting other people to get involved and form a team quickly and put all the brains together. But even though you are too many cooks spoil the soup, is the adage that you know. So there should always be one leader to control them and guide them, so that it will be a coordinated work and not a haphazard free for all way of treating these patients. So this is the almost in every medical specialty has now followed this crisis management concept, including nursing, pharmacy, and emergency medical services. And the primary purpose is provide a team-based approach, averting and mitigating the medical crisis. This is the main aim of our goal of our CRM training. Now, it can be classified into 8 teamworks. And first thing they insist on is a good leadership. And even though you should be aware of the situation, you should have a good leader who can control and who can guide all the team members to do their work. And second is effective communication. And they insist that this communication should be loud and clear. Whenever you ask one of your teammates or a colleague to draw a particular drug, you must say it very clearly. So there have been errors because of either the person who has been given the instruction did not hear you at all, or heard you but heard you wrongly, or thought of something else when you said something because of the improper communication. So the communication should be very clear and loud, and there should be no ambiguity in the minds of the person who is receiving the instruction. And then we must anticipate and plan, because of course crisis suddenly occurs. They always say earlier adage, another adage about anesthesia is 99% boredom and 1% panic. That is how they describe the specialty of anesthesia, because majority of the time everything goes on smoothly. But 1 to 2% of the time suddenly some crisis occurs and you get into a problem. So in that situation, if you are already anticipating and if you are been trained how to manage that, and with a proper planning, you can utilize that. So it is not that you anticipate and plan at the time of crisis, but you should be tuned to this. You should be able to anticipate that such a problem can happen. For example, if you are going to give anesthesia for a child with bronchial asthma for adenotonsillectomy, you should anticipate that at any moment the child can go into bronchospasm. Right from the time of induction to maintenance and extubation, you must anticipate and you must plan what are all the drugs you should keep ready, whether you are going to use nebulizer intraoperatively through the endotracheal tube, or you are going to give IV drugs like deriphyllin, and how are you going to prevent the occurrence of the bronchospasm by proper depth of anesthesia, proper prevention of the stimulation of the very irritable or reactive airway. So if you anticipate and plan for the case accordingly, then the whole crisis can be prevented. So that is what is called the anticipation and planning. Then you must have all the resources available and you must be able to utilize that. And you must do the workload distribution correctly. You must ask someone to load deriphyllin when there is a bronchospasm. Another person should make sure that the child's lungs are not ventilated with so much pressure to produce a pneumothorax. And another person should take care of what's the saturation and keep on telling you how the patient's condition is. Another person should take care of the cardiovascular status. Like that, the workload should be distributed evenly. And the situational awareness, probably this should come in the second position instead of the sixth position. This situational awareness should come in the second position. And you must triage and prioritize. You must be able to understand which situation or which crisis is more risky to the life, and address that crisis more than the other one, which is less harmful or less affecting the life of the patient. So this is called, especially in trauma, in a patient has got a fractured femur and pneumothorax. Which one will you attend first?
Pneumothorax, sir.
Pneumothorax, because that will kill the patient immediately if you don't drain that. So that is what is called triage and prioritization. So you must know which one is to be attended first and which one can wait. Like that, this is the another part of the CRM. And lastly, the management disruptions. While you are doing the resuscitation or crisis management, there are likely to be disruptions. Suddenly, the ECG lead may come up and your ECG monitoring may not be properly done. In that situation, you must immediately put a hand on the pulse and see whether the pulse is palpable or not. Or suddenly the pulse oximeter probe may come off, or so nobody would have noticed that. So this sort of disruptions can happen, which you should be able to manage and then take a further decision on that. So each one like that, I'm going to explain a little bit in detail. Effective leadership is very much required, and the team leaders are responsible for assigning the roles to other members and monitoring their activity. and leaders should maintain a global view of crisis, avoiding fixating on isolated details. So you must take an overall assessment of the situation, and they should continuously generate key information and act according to the reaction from the patient. For example, you give adrenaline for an anaphylaxis. You think you are given prochronium and patient develops immediate swelling and bronchospasm, and you make a diagnosis of anaphylaxis. What is the first drug of choice for anaphylaxis? Epinephrine, isn't it?
Epinephrine.
So epinephrine you give, and then somebody gives without knowing the correct dose, and the patient goes in for a tachycardia of 170, 180. Then what will you do? The anaphylaxis is treated, but the side effects of adrenaline is going to cause some problem. So you should try to reduce the heart rate by giving a short-acting beta blocker to prevent the tachycardia-induced pulmonary edema. Okay, so this is how you do the adaptive. This is called the dynamic manipulation of the situation. So, and you may not know which patient is going to develop such problem. Some patients, even after giving one ampoule of adrenaline, they may still be in bradycardia. There you can boldly give another dose. Whereas if another person given the first dose itself develops a very severe tachycardia, you have to adjust your dosage according to that. This is called the adaptive dynamic situation. And the leader should not only be open to feedback, they should get the feedback from the team members and make them, if somebody tells a correct suggestion, the leader should take it up instead of throwing his ego and saying, who are you to say and why should I act according to your suggestion? That should not be there, because it's a teamwork. Everybody's opinion should be taken, and whichever is going to be the best for the patient, that should be utilized. And finally, leaders should balance confidence and humility. This is again a behavioral problem. That is, leader should not think that he is the ultimate person in the whole management, and should not think mean or low of other team colleagues. He must give respect to each every one of them. And if somebody in the team makes a mistake, you can correct and then tell him this is not the thing to be done now. You have to correct it, do this is the way I think that is the correct way. Put it in a lighter or a polite way. Don't immediately shout at them and say, you stupid fool, you don't know even this. That sort of behavior should not be there. So these are the qualities the leader should have. Then communication, it should be failure in communication is the main reason for errors. The effective communication is the critical for success. And it should be complete, clear, brief, and timely. And it should be a closed loop communication. That means you have to, as I told in the last class about closed loop and the open loop, where you have to get the feedback from the messages from the person to whom you are giving the instruction. That is, you say you give adrenaline intravenously in an anaphylaxis situation, and your assistant has given that. Immediately, the assistant should say, sir, adrenaline administered. This is the time. Now it is 1 minute more after giving the drug. So like that, he can inform and keep in communication with the leader. And team aim is to be assertive, yes, respectful. So you must say that you have done the work, but at the same time show some respect to the leader without saying that or causing any misunderstanding with him. And finally, there will be bi-directional communication to facilitate knowledge and sharing and inquiry. This can come as a later discussion, not during the crisis time. Later on, after the patient has been revived or whatever happens to the patient, at the end of the procedure or the crisis, you must sit and discuss what should have been done, what would have been better, and how this has been managed. All that discussion, that is called the bi-directional communication to facilitate improving the knowledge and managing the next crisis much more efficiently and effectively. Then anticipation and planning, as I said, I gave you the example of a bronchospasm patient coming for a surgery. So sudden unexpected events can have serious negative consequences in their medical teams. So planning can take place long before an emergency or immediately before a high risk situation or during the situation. So by anticipating and planning can develop a shared mental model, prioritize tasks, promote the way to manage, increase the stress and anxiety, and optimize patient care. So these are the advantages of anticipation and planning. Then resource utilization. There are three types of resources. One is personal. You need a lot of help in the form of OD assistants, nurses, your junior colleagues. So it should be a personal oriented resource, or it may be equipment. Supposing there's a ventricular tachycardia and arrest, you have to shock the patient. You should have the defibrillator ready. So that should be available. All the drugs that are required available. All the gadgets which are like central line insertion or oxygenation equipments. All these things should be checked and kept ready, and cognitive skills also or aids also to be kept ready. The accessibility and the utility of these resources varying depending upon the clinical setting, time of the day, and clinician expertise. And it is apparent during routine patient care, but easily overlooked during stressful time. For example, in 1995, when I was working in Stanley, we had a patient for cleft lip and palate, a grown-up 21-year-old girl. She had had the lip and palate operated as a baby in a hospital in North India. And she came for nose correction because she was about to get married, so she wanted to have a proper nose, which was a little disfigured because of the cleft lip and palate. So she was operated for nose correction. And during intubation, the PG who intubated failed to notice that the tube was not in the trachea. And unfortunately, during that time, we never had a pulse oximeter or monitors. It was a manual monitoring with pulse in the palpating the pulse and then the Swinburne manometer tied to the arm and checking the BP every 10 minutes manually. And unfortunately, the patient did not show any cyanosis or anything, and suddenly she arrested. So when she arrested, we revived her, and we tried to revive her with immediate CPR, and there was no ECG monitoring, so we did not know whether it was bradycardia and arrest or ventricular tachycardia. What happened, nobody knew, and we did not have a defibrillator at that time to give a shock. So, but luckily, one of the surgeons made a thoracotomy and immediately went in for direct cardiac massage, and we were able to revive the patient with that. So, what we routinely do without checking all these things may go on well, but when it comes to a crisis situation, unless you make a routine drill of checking all the equipments every day in the OT, whether they are available, even starting from the simplest ambu bag to the most important defibrillator, everything should be checked and kept ready every day, so that, as I said earlier, anesthesia 99% boredom goes on very well smoothly without any hitch. But the 1% when it comes, it is a single that patient's life. Even though you anesthetize 100 patients, if you lose one patient, it is the family's loss. Even though you may say that I have lost only one of my cases, but the loss is heavy to the family. So from that angle, if you understand that, then you will be able to understand the importance of this topic. So checking the equipment and keeping them ready in stressful situation is very, very important. And continuous survey of the environment is important. And mobilize all the resources, and team should call for help early and activate additional resources. Then workload distribution, because there should be clarity, and we must allot the work to the appropriate personnel also. And situation awareness, I think, as I told, this should come immediately after leadership. And they receive relevant data from the surroundings, process the information, and utilizes. And team members should continuously reassess the patient and clinical environment and remain sensitive to that changes. And periodically check. So this is the second line. I gave you the example of administering adrenaline and some patient not getting a severe tachycardia and other patient getting unacceptable level of heart rate increase. So we must know according to that and try to adjust and try to treat that, whatever reaction or the response from the patient. And then cross-check, establish shared mental model and establish the teams proactive. So the some patients may be, sometimes you may have to come with a innovative idea at the time of crisis. And for example, when you are having a severe hemorrhage like what Balasundaram described, if there is no rapid transducer, you can start 3-4 lines and pump the blood requesting. Again, I can share another example for this. When I was working in Stanley, we had a patient who was only a 19-year-old boy with a huge AV malformation in the scalp. And he was related to one of the cardiothoracic surgeons there, and he was also present in the theater. And the surgeons, our theater plastic surgeons, were operating on that. And there was a huge bleeding that was going from because it was in the posterior aspect of the scalp, all the blood was draining. Patient was operated in a little head up tilt position, and all the blood was dripping through the drip onto close to the feet of the operating surgeons. So 3 surgeons were surrounding and standing the head of the patient, and I could not assess the amount of blood loss. Suddenly, I found again this was a situation where we never had multi-parameter monitors like today. So I used to have a constant hand on the pulse of the patient, and I found the pulse is becoming weak. And at one stage, I could not palpate the pulse at all, and I told the surgeons to stop. And they also said there is no bleeding in the site at all, sir. Then I told them, you have already drained all the blood by your surgery. So I have to first revive the patient. So I asked them to stop, keep the wound packed, and then we started. In that situation, we could not put a central line also because the patient was in a head-up situation. So we started 4 lines. Already one line was going on one arm. So another one was in the elbow, another one on the other arm, 2 drips on the leg. And we immediately got 4 or 5 bottles of blood. And I asked everyone in the OT to apply a BP cup and then around the bottle and squeeze the blood. And during that time of resuscitation, I told the surgeons to quickly finish off the surgery because now the bleeding is less. You can identify vessels and then clamp them and cut it off. And by the time they finished the surgery, we could transfuse 4 to 5 units of blood, and pulse came back and BP came back, and patient got revived without any further hitch, and surgery also got completed, and we could extubate the patient on the table. So that was the situation where you have to adapt yourself to do that according to the need of the hour. And triage and prioritization, again, I have given you how to select which is more important complication rather than the lesser life-threatening situation. And management disruptions, they also occur frequently, and they should be able to, you should not get distracted from these things and then try to complete your task without getting distracted. So this is all the stuff, the entire 15 topics given in Miller. I found these 8 subdivisions will give you a clear idea and the easy way to answer the question. And so this can be followed if this question is asked in your examination. Okay.
Okay, sir. Yes, sir. Thank you, sir.
Anybody having any other doubts? Vidya?
So no, sir.
Was it clear?
Yes, sir. It was very clear, sir.